Hello, can you start?
Yes. Yes, I'm wondering why you guys have not begun.
Okay,
Can we
so
go, please?
we start the presentation. I think. Oh, sorry. So I think Patrick Wambua can start as well.
So, good evening, everyone. Kindly confirm that you can hear me.
Yes, we can hear you.
Okay, so my name is Wambua Frederick. I'm going to start us off. Today we are discussing family planning. Our facilitator is Dr. Mogeni. So I'm going to start us with the definition and then public health significance of family planning. So family planning is the ability of individuals and couples to anticipate and attain their desired number of children and the spacing and the timing of their birth. So basically, it is the planning of when to have children and the use of birth control and other techniques to implement such plans. So the objectives of family planning include to avoid unwanted birth, to regulate the intervals between the pregnancies, to control at which age the birth will occur, and to determine the number of children in the family. Next slide, please. So what is the public health significance of family planning? So basically, as we have said, one is to prevent unintended pregnancies. We also have a slow population growth, which conserves resources, improves health and living standards. We also have improved quality of life, better health, less physical and emotional stress of life, better education, job, and economic opportunities. We also have a reduction of perinatal, neonatal, infant, and under 5 mortality. And all these benefits are enjoyed by the couple, the children, and the other family members, the community, as well as the country as a whole. Next. Next slide, please. So we had a survey that was done in Kenya. That is the Kenya Demographic and Health Survey on 2014, which showed that the knowledge of at least one contraceptive method is universal in Kenya. It also showed that more than half of the currently married women are using contraceptive methods, that is around 58%. And the most popular modern contraceptive methods that were used by married women are injectables at 26%, implants at around 10%, and then the pill at around 8%. So use of modern methods has increased over the last decade from 32% in the last survey that they did in 2003 to 53% on the 2014 survey. So the public sector remains the major provider of contraceptive methods at around 60%, being provided at the government sources. Next. So the survey also found out that 31% of family planning users contribute use of a method within 12 months of starting its use. And then the reason for discontinuing the method, they said that it was side effects and health concerns at around 11%. And then the 18% of currently married women have an unmet need for family planning services, with 9% in need of spacing and 8% in need of limiting the use. Next. We also have a poor, rural, and uneducated and disempowered women use contraceptives less as compared to the rich and urban, educated, and empowered counterparts. The study also found that the cost of purchasing contraceptives has been listed as a deterrent to modern contraceptive use among women, and particularly the use of intrauterine devices. Then about 1 in 3 couples in Kenya will likely discontinue contraceptive use within a year. Next. We also have over 90% of women reported that they supported the family planning, but contraceptive prevalence rate in Kenya is greater than many other African countries. So this is a pie chart showing the methods of contraception using at a higher rate at 47.9%, followed by implant as the dominant method. So now I welcome the next presenter to take us through the next part, which is the classification family planning method.
Okay, I'm the next presenter. Can you hear me?
Yes,
Someone?
Flavian.
Oh, thank you. So I'm going to talk about the classification of family planning methods. So we have temporary and permanent methods. So on the permanent methods, we have female and male. So for the male, there is vasectomy as a permanent method. Then there is in the females, we have tubal occlusion, that is bilateral tubal ligation. And then we have bilateral salpingectomy. On the permanence of bilateral tubal, someone please mute your audio. Okay, so that is on the permanent. Then on the temporary, we have hormonal and non-hormonal. So on the non-hormonal methods, there is barrier methods, natural contraception, intrauterine device. So the intrauterine device can be hormonal and non-hormonal depending on what the patient prefers. And then there is hormonal, which has various methods under it. So for the barrier methods, we use there is mechanical and chemical, and or a combination of the two. So for the mechanical, we have condoms. For the male, there's just condoms. Then for the females, they can use a condom or a diaphragm or a cervical cap. The person moving the slides, I'm on the next slide. Yes, and then on the chemicals, we have spermicides. So there are creams and there are foam tablets. There are also sponges that are all used. They contain spermicides. So when they are applied and then someone has sexual intercourse, there are spermicidal, so the person doesn't get pregnant. And then so you can combine the two depending on the effectiveness of the method you choose. The natural methods, next slide. There is a withdrawal, which is also called coitus interruptus. There is the breastfeeding period where there is lactational amenorrhea due to hyperproduction of prolactin. And then this will lead to an ovulation. So when there is an ovulation, even if there is sexual intercourse, it will not lead to conception. And then there are rhythm methods where someone picks the dates in their cycle when they are safe. So you can use a calendar, you can use the temperature rhythm, considering the fact that when someone is ovulating, they have high temperatures. So you can use that as your way to monitor the rhythm of the cycle. IUCDs, as I said, are non-hormonal or hormonal, depending on the one you want. Someone will elaborate on that. And then now on the hormonal contraception, we have, move the slide, please. We can have several methods of administering these hormones. It can be oral, parenteral, or you can use a device to administer it. So there are listed some of the oral or some of the parenteral methods. So the oral methods, we have the hormones that are used that are going to be explained as we continue with the class. Thank you. Next presenter.
I'm the next presenter. Zaid, can you kindly change the theme so that it's visible?
Baby.
Hold on, let me just check. You can just carry on out. I'm unable to see.
Pardon? Okay, let me just present. I think we'll change the theme before we share the slides with the class. Can someone kindly confirm that you can hear me?
Yes, yes.
Okay, so I'm going to talk about the PAL index. So basically the PAL index is defined as the number of contraceptive failures per 100 women years of exposure. So it uses the denominator of the total months or cycles of exposure from the initiation of the product to the end of the study or the discontinuation of the product. Next slide. It's also called the pulse rate, and it's the most common technique that is used in clinical trials for reporting the effectiveness of birth control. So the information needed to calculate the PAL index for a particular study is the total number of months or cycles of exposure by women in the study and the number of pregnancies during the study. So based on the months, PAL index is calculated as the number of pregnancies times 12 over the number of study of participants times the number of months in the study. All of that you multiply by 100. So, and based on the cycles, the number of pregnancies in the study is divided by the number of menstrual cycles experienced by women in the study and then multiplied by 1300. So it's 1300 instead of 1200 on the basis that the length of the average menstrual cycle is 28 days or 13 cycles per year. So the PAL index is sometimes used as a statistical estimation of the number of unintended pregnancies in 100 women years of exposure. So for example, 100 women over 1 year of use or 10 women over 10 years of use. So it's also sometimes used to compare birth control methods, and a lower PAL index represents a lower chance of getting unintentionally pregnant. So there's a table or rather a graph there that shows different values of PAL index according to different methods of contraception. So like I said, a lower PAL index represents a lower chance of getting pregnant. So for example, if you're using no method, you'll have a higher PAL index. So for example, let's say no method will have like 85% PAL index. Using a sponge, we'll have a 32, and vaginal suppositories, 26, and so on and so forth. You'll see the graph when I send you the slides. So we have shortcomings of the PAL index in estimation of effectiveness of birth control. So one of them is there's no information on factors other than accidental pregnancy, which may influence effectiveness of calculations, such as side effects or loss to follow up or dissatisfaction. And there's also the time factor in calculation of the PAL index. And there's also a difference in population, like we have different populations, which is not factored in the calculation. Thank you. We can move on to the next presenter.
Okay, my name is Amwata. I'll take you through the medical eligibility criteria. Please confirm that you can hear me.
Yes.
Okay, so next slide, please. Okay, so the medical eligibility criteria is basically a document which has been developed by the World Health Organization as a part of the process of improving the quality of care in family planning. So what it gauges is the safety of various contraceptive methods for use in context of specific health conditions and characteristics of the patient who wants to use a given contraceptive method. So primarily, it's supposed to determine whether a method will worsen a medical condition or create additional risks, or whether the medical circumstance may make the contraceptive method less effective. So all this is based on clinical and epidemiological data in a way of having evidence-based practice. Next slide, please. So the purpose is to act as a guideline for family planning practices on available evidence. It's also supposed to address misconceptions regarding who is able to use different family planning methods. It's supposed to reduce medical barriers in provision of contraceptives, and also to improve access to quality of care in family planning. I don't know if it's just me. Okay, then next slide. So it's based on utilization of evidence, which is gathered from research, and then the research is used in the development of the medical eligibility criteria, which helps in improving the quality of family planning health services. Next slide, please. In the presence of a given individual characteristics or medical condition, what this tries to determine is which contraceptive method can be best used, but not best to mean that that is what you prescribe to the patient. Still, the patient autonomy comes first, and the patient has a right to decide which method they want. So some of the medical characteristics that are considered include the age, weeks or months postpartum, breastfeeding status, puerperal sepsis, dyslipidemia, history of cardiovascular disease, and so on and so on. For each medical condition or characteristic, the contraceptive methods are placed into one of four categories. Next slide. The four categories being category 1, a condition for which there is no restriction for the use of the method. Category 2, where the condition, the advantages of using the method outweigh the theoretical or proven risks. And then category 3, where there is theoretical or proven risk, there is theoretical or proven risk outweigh the advantages of using the method. And then for category 4, where it's unacceptable, there is an acceptable health risk if the contraceptive method is used. So so those are the four categories when you're using the given this document. Next slide. So all this information is available on an app called the Mech Wheel, which you can get in your Play stores. So basically, it has all these different medical conditions or different medical characteristics of the patients, and then the different types of contraceptive methods that can be used. And those methods are categorized into either category 1, category 2, category 3, category 4. Category 4 being the risks are way higher, so you're not supposed to use that contraceptive method. So it's basically just a wheel which you move to fit your patient criteria. Next slide. So for category 1 and category 2, basically you can use those methods because either there is no risk at all, or even the risks that either have been proven theoretically or clinically are not, they are way less compared to the advantage of using the contraceptive method. But when it comes to category 3 and category 4, basically the advice is not to use these methods for those particular individual characteristics or medical conditions. Next slide. So that mainly applies for the temporary methods of contraception. But for the permanent methods, or for male or female sterilization, we use a different classification. And these are either classified as A, C, D, or S. A being accept, where there is no medical reason to deny sterilization to a person. C being caution, where the procedure is conducted in a routine setting, but with extra preparation. D being delay, where the procedure is delayed until the condition is evaluated. And S being special, where the procedure is undertaken in a setting with an experienced surgeon. For example, if you're having a patient with coagulation disorder and you want to take them for, let me say, male sterilization, they'll be classified as S, where you need like a special an experienced surgeon or staff to carry out the procedure. So basically, that is how you categorize the different patients based on the clinical conditions that they have. So you can move on to the next presenter.
Good afternoon, everyone. So my name is Faith Okota. I'm going to take us through oral contraceptive pills. So by definition, the oral contraceptive pills are medications that are taken by mouth to help prevent conception and therefore pregnancy. Broadly, they can be classified into combined pills that contain estrogen and progestogen. And we have the progestogen only containing pills. So I'm going to cover the combined pills part. Someone else is going to cover the progestogen containing pills. So for the combined pills, normally we have combination of estrogen and progestogen. And estrogen, the commonly used preparations of estrogen include ethinyl estradiol, and a few combinations contain mestranol. For the progestogen part, we have norethistérone, we have levonorgestrel, and then we have ethanodiol, and others that are listed there in the slides. Next slide, kindly. So the mechanism of action of combined oral contraceptives are mainly four. So we have the blocking of ovulation. So for this one, we have, when you give, as I've said, they contain both estrogen and progestogen. So we have the estrogen part will carry out a negative feedback on the anterior pituitary gland to prevent the release of gonadotropins, and therefore subsequently preventing the release of follicle stimulating hormone that interferes with the maturation of the follicles. And then the progestogen part mainly works by preventing the release of luteinizing hormone, therefore preventing ovulation. We also have, in combination, they alter the cervical mucus viscosity, which is also important in the process of fertilization. Then we have also, they have a concert effect on the endometrium and therefore interfering with implantation. And then we have slowed tubal motility, which is mainly a function of the progestogen part. Then next slide. Okay, so based on the amount of estrogen in the combined oral contraceptive pills, we have generation. So normally the combination we have estrogen levels of about 20 to 50 micrograms that are normally commonly used. So based on the portion of the estrogen that is used, we can have 4 generations. So we have the first generation combined oral contraceptive pills, and the examples are the ones that are listed there. We can see progestin, norethinomycin. Yeah, you can read that. I'm having a difficulty with the pronunciation. But then the first generation normally contain estradiol of more than 50 micrograms. We have the second generation containing less than 50 micrograms of ethinyl estradiol. Then we have the third generation. The examples include progestin, desogestrel or gestodin, and others. Then we have the fourth generation that contain progestin, dospirenone, and sometimes defined as those containing drospirenone, dinogest, or normogestrel acetate. Then we have types. Kindly the next slide. So we have types. So the types is based on the mechanism of release of the contents of these combined oral contraceptive pills. So we have 4 main types. We have the monophasic, biphasic, triphasic, and the 91-day cycle pill. So for the monophasic one, we have each tablet that contain this hormones, they release them at a fixed amount. So if they're releasing both estrogen and progestin at a fixed amount. For the biphasic ones, we have the estrogen being released at a fixed amount, while the progestin is released in increasing amount in the second half of the cycle. Then for the triphasic one, the amount of estrogen again is fixed, and the progestin is released in increasing amount in 3 equal phases. That is after every 7 days of the cycle. Then we have the 91-day cycle. Next slide. So these combined oral contraceptives, they have some beneficial effects, just as the same way they have some deleterious effects. So for the beneficial effects, we have for control of menstrual symptoms, e.g. if someone is having irregular periods or they're having intermenstrual bleeding, you can use these pills to treat that. They can also be used to treat endometriosis, adenomyosis, and polycystic ovarian syndrome because of the effects of estrogen, mainly on the growth of these tissues and these abnormalities. Then we have iron deficiency anemia, we have premenstrual tension, we have uterine fibroids and functional cysts of the ovaries. Again, I know we understand the physiology of these pathologies when it comes to the estrogen as an hormone. So when you give the estrogen, you are counteracting the effect that it has on the growth of these pathologies that are associated with the ovaries and the uterus as well. Next slide. So there are some few pharmacokinetics that we need to understand that can be significant when it comes to failed use of these combined contraceptive pills. So the metabolism of these pills happens in the liver using the hepatic cytochrome P450 enzymes, and that means that if this patient has medical conditions or for some reasons you are prescribing certain drugs that uses the same metabolic pathway, then you would want to either adjust the dosages or maybe advise the patient on the effect of these drugs when it comes to failure in terms of preventing consumption. So we have rifampicin, we have carbamazepine, we have phenytoin and griseofulvin, and also we have broad spectrum antibiotics like amoxicillin and doxycycline. And this is very important because these are drugs that are commonly used in our setup. Next slide. So before I move to the postcoital emergency contraception, there is maybe just something that I want to mention on the side effects of these combined pills. So we can divide the side effect system. We can have cardiovascular effects. We have carcinogenicity, we have metabolic effects, and we have the effects on the serum lipid levels. So for the metabolic effects, we know that estrogen has an effect on glucose metabolism. So we can have abnormal glucose tolerance that can be associated with use of these pills, and sometimes you can have weight gain, common in women who are taking the nor testosterone derivatives in these combination pills. Then for serum lipids, estrogen is helpful in increasing high density lipoprotein, while it decreases the low density lipoprotein. But then progestogen, on the other hand, antagonizes that effect. So sometimes you can have estrogen dominant preparations being the best when you have individuals with elevated serum cholesterol. And then for cardiovascular effects, already, if we are talking about like the combination that are more progestogen dominant, then you can have increased risk for having embolism and thromboembolism as well. So we have cardiovascular diseases, thrombophlebitis, hypertension, increased incidence of myocardial infarction, cerebral and coronary thrombosis as well. And then we have others like skin changes. Remember, these are steroids, so we can have skin changes, e.g. acne, and increase in pigmentation. We can have amenorrhea of variable duration on cessation of taking these pills. And also we have mild nausea, flushing, dizziness, depression, or irritability. So on postcoital emergency contraception, we have oral administration of levonorgestrel alone at 1.5 milligrams. That is the one that is normally, the dosage that is normally usually used, or in combination with estrogen. And this is normally most effective when taken within 12 hours, but it is still effective even if taken in 72 hours. The commonest side effect is nausea and vomiting. Next slide. So we have patches. We have the topical patch. This normally contains a combination of norelgestromin and ethanyl estradiol, which is estrogen derivative. So this is normally applied to a clean, dry skin on either the shoulders, the upper arms, the buttocks, or the abdomen. And normally should be applied to, you should avoid applying it on an inflamed area of the skin or in areas where tight clothing may rub it off, which may reduce the effectiveness. So again, it is not applicable, or rather it is equivocal when you want to use it in women who are obese, because it will interfere with absorption because of the large amount of subcutaneous fat. Next. So normally a new patch is applied on the same day of the week. Say if you advise the patient to start taking it on Monday, then the other Monday of the next week, the patient applies it again, and then the other Monday. So you do it 3 weeks in a row. So the first patch is applied either on the first day of the menstrual period, or after 7 days, or immediately following the cessation of menses. On the 4th week, no patch is applied. So you apply it 3 times, as I've already said. So menstruation should begin during that time, the time that there is no patch. And this 4-week period is considered a full one cycle. So another 4-week cycle is started by applying a new patch following the 7-day patch-free period. Next. I think I've already discussed the common side effects that are associated with these combined oral contraceptive pills. Yeah, next slide. So contraindications, this would be, if you have understood how they cause their side effects, then the contraindications now should be easier for you to understand. So if a patient already has cerebrovascular disease or coronary artery disease or myocardial infarction, you don't want to put them on these combined oral contraceptive pills because of they can cause thromboembolism and so forth, deep vein thrombosis, pulmonary embolism, congestive heart failure. If they're having severe hypertension, diabetes, again, we have already talked about that, and active liver disease. For the role of estrogen on carcinogenicity is equivocal. I think maybe Daktari will clarify on that. On my reading, most of the studies were not conclusive. Yeah, the next presenter can take over. Thank you.
Okay, so my name is Gumato. I'll take us through the next part, which is progestin only pills. So by definition, this is these pills are devoid of any estrogen compound, and it contains very low dose of progestin as compared to now the combined oral pills. So the examples include levonorgestrel, which is 75 micrograms. Okay, those are the examples. You'll go read for yourselves. So the progesterone, they're also known as mini pills. So it is taken daily from the first day of the cycle. Next slide. So the mechanism of action, I think Faith has already discussed, but one, the main mechanism of action is by increasing, making the cervical mucus thick and viscous to prevent sperm penetration. Also, it makes the endometrium atrophic by decreasing the number of glands and also the size of endometrial glands, so that, and then this hinders implantation. So it also reduces cilia motility in the fallopian tube, thus slowing the rate of transport. It also causes a cessation of ovulation in about 2% of cases. Next slide. Okay, so on the efficacy, so the serum progestin levels peak approximately 2 hours after administration, and there is rapid distribution and elimination within 24 hours and return to normal levels or baseline levels. So greater efficacy is achieved with consistent administration. And as we have said, you have to take the pills every day at approximately the same time. So failure rates with typical use are approximated at 7% in the first year of use. However, there can be variations in these failure rates. Next slide. Okay, so how to prescribe? So the first pill has to be taken on the first day of the cycle, and then continuously. It has to be taken regularly at the same time of the day, and there must not be, there's no break in between the packs. So if there's delay in intake of the pill for more than 3 hours, so the woman is advised to take the missed pill immediately and to take the next one as scheduled. And for the next 48 hours, you should be advised to take backup contraceptions like the barrier methods. Next. So the advantages of progestin only pills, the side effects, they do not have side effects that are attributed to by estrogen in the combined oral pills, like the risk of thromboembolism and cardiovascular diseases. There's no adverse effect on lactation, hence it's suitable for lactating mothers. It's easy to take as it does not have any on and off periods. It may be prescribed to patients who the combined oral contraceptives are contraindicated, like in hypertension, diabetes, epilepsy, smoking history, or thromboembolism. There's reduced risk of also PID and endometrial cancer. Next slide. Okay, so also it has non-contraceptive benefits such as decreasing dysmenorrhea, decreasing menstrual blood flow, and also decreasing premenstrual syndrome symptoms. Next slide. Okay, so on the disadvantages, so as we have said, they have to be taken every day, approximately at the same time, and should not be delayed for more than 3 hours. So the biggest disadvantage is compliance. And then you also have side effects such as acne, nostalgia, nausea, headache, breast tenderness, breakthrough bleeding, and also amenorrhea in about 20 to 30% of cases. There can also be simple cysts, simple ovarian cysts, and also failure rates of about 0.5 to 2 per 100 women years of use, and failure is more in young as compared to women over 40 years. And you should discourage this method or avoid this method of contraception if women are using other drugs that induce the liver microsomal enzymes, like the anticonvulsants and also anti-TBs. Okay, so the contraindications, you have pregnancy, unexplained vaginal bleeding, recent breast cancer, arterial disease, and thromboembolic diseases. The next presenter. I'll take you through the injectables contraceptives. So the preparations commonly used include the dipomedroxy progesterone acetate, DMPA, commonly called Dipo, and the norethisterone enanthate. Both are administered IM, so you can inject them in the deltoid or the gluteal muscles within 5 days of the cycle. The injection should be deep, Z-track technique, and the site should not be massaged. I was trying to see the reason, and I was seeing that it causes increased absorption of the drug. And then if you're giving Dipo, you use a dose of 150 milligrams every 3 months, 13 weeks, or 300 milligrams every 6 months. And if you're using norethisterone enanthate, you give a dose of 200 milligrams 2 monthly. So we have a sub-Q Dipo, 104. It contains 104 milligrams of DMPA and is usually given subcutaneously over the anterior thigh or the abdomen, and it suppresses ovulation for 3 months as it is absorbed more slowly. Then you can also have monthly injectables such as cyclophan. When it is used, the monthly bleeding becomes lighter, shorter, or less frequent. Spotting and unexpected bleeding can occur. So the mechanism of action of using Dipo, it inhibits ovulation by suppressing the mid-cycle luteinizing hormone peak, and it also causes the cervical mucus to become thick and viscid, preventing sperm penetration, and it causes atrophy of the endometrium, preventing blastocyst implantation. Yeah, if you're keen, you'll note that these are the side effects of progesterone. So all the progesterone containing pills or IUD or injectables will have the same mechanism of actions. So in the advantages, it eliminates the regular medication as imposed by the oral pill. Like you've seen in the progestin only pill, the patient has to take medications every day at a particular time for a long duration of time. And for the Dipo, at least they can get an injection once in every 3 months. And it can also be used safely during lactation, beginning 6 months after childbirth. It probably increases the milk secretion without altering its composition. And then there are no estrogen-related side effects, and it reduces menstrual symptoms, e.g. menorrhagia or dysmenorrhea. This is because when they use these progesterone injectables, some patients have lighter menses, and most of them can even have amenorrhea. So they'll have it will be advantageous for patients with menorrhagia and dysmenorrhea. It is protective against endometrial CA because it's an estrogen-dependent tumor. It can be used as an interim contraception before vasectomy becomes effective, and used in reduction of PID, endometriosis, ectopic pregnancy, and ovarian CA. And the non-contraceptive benefits, it reduces the risk of salpingitis, endometrial cancer, iron deficiency anemia, and sickle cell problems because it reduces menorrhagia. So for the disadvantages, the failure rate is 0 to 0.3%, and there's a chance of irregular bleeding and occasional amenorrhea. Then return to fertility after discontinuation is usually delayed for several months, 4 to 8 months. However, with norethisterone, the return of fertility is quicker. And then loss of bone mineral density has been observed with long-term use of Dipo. And overweight patients with insulin resistance can develop diabetes. Other side effects include gradual weight gain and mild headache. So this side effect should be explained to the patient before they make an informed decision to take this medication. So the contraindications are women with higher risk osteoporosis because it causes loss of bone mineral density, pregnancy, unexplained vaginal bleeding, recent breast cancer, arterial disease, and thromboembolic disease. Yeah, so I'll welcome the next presenter.
So I'll take you through the IUS, Mirena. My name is Kamore. So for IUS is a type of intrauterine device. So intrauterine devices can be broadly classified as hormonal or non-hormonal. So for hormonal, we have the likes of Mirena and Lita, Skyla, and we have non-hormonal like the copper T. I think someone else will tackle the non-hormonal ones. So in our setup, mostly we have the non-hormonal, with the copper T being the most commonly used. But in this discussion, we'll be discussing about the hormonal containing intrauterine devices system. So mostly they contain progesterone analogs, and mostly they contain levonorgestrel releasing intrauterine system. And on this slide, you can see the examples of such. So especially for Mirena, which is talking about releases, it has about 52 milligrams per device, and they tend to provide contraception for around average of 5 years. It can go up to 6 years, but it's usually removed after 5 years for the sake of safety and to avoid getting, the contraception failing, especially the last year of contraception. These levonorgestrel containing intrauterine devices, they are very, very effective. They are one of the most effective method of contraception, with 99% effective, 99 plus effectiveness. So meaning the failure rate is very low compared to most of the other contraceptive methods. And like I've highlighted, that they last for 5 years plus, but mostly we continue after 6 years. After 5 years, sorry, they can go up to 6 years. The next slide, sorry. Next, yes. So they release 20 microgram of levonorgestrel per day to the uterus, and I think we have been highlighting the functions and mechanism of action of progesterone containing hormonal contraceptives. So it is the same mechanism. It's only that now this one releases small doses of progesterone for a longer time, so you can use it for like 5 years or so. So meaning the effect will be the same as what we have been discussing about the progesterone containing, and the side effect will still be the same. The side effect that you find after using progesterone. So meaning it's more of a repetition of what we've been talking about. The next slide, please. Next one. Next slide. Next. Yes, so I think this one I have already highlighted. You can go to the next slide. Next one. Yes, so there are some things you consider before you you start levonorgestrel. If you remember the physiology of the menstrual cycle, you remember the first phase, we have the follicular phase. Then the second phase, we have the secretory phase, whereby mostly it is progesterone. From day 14, if you're talking of 28 cycle. So from mean cycle, we have progesterone now coming in, and from day 0 to day 14, we have estrogen coming in. So it means if you give your levonorgestrel between day 0, in the first cycle, most of the time, especially when you give within the first 7 days of the menstrual cycle, whereby we have mostly estrogen acting, in most cases, you may get some failure rates. So because of that, when you're starting the levonorgestrel intrauterine device, you need first for the 7 days, you need to, if you start within the 7 days of the cycle, you need to supplement with another, you don't need to supplement with another, you don't need to supplement with another contraception. But if you start after day 7 of the menstrual cycle, you remember from around day 13, day 14, that's where we get the ovulation. And remember, if you have intercourse after day 7, the sperm may stay up to around 4. It's viable for around 3 to 4 days. So it means 3 days you subtract from around 14, you come up to around day 10. So it means if you use it around that time, it is wise to supplement with another contraceptive to prevent pregnancy. Next slide, please. Next one. Yes. So now this one talks about the how you can switch from someone who has been on another contraceptive. So this intrauterine device, especially containing the progesterone, you can insert them anytime. And you can remember you have said you can insert them during the active use of the previous method. So let's say, for example, someone has been on maybe some oral contraceptive. You can concurrently use the 2 for like 7 days. Then you stop the oral contraceptives and you continue with the hormonal you continue with the intrauterine device. So that means the reason why you want to supplement the 2 is just to make sure you don't create a gap whereby you may have failure of the contraception where you are switching from one contraceptive to another. So we can go to the next slide. Yes, so these are switching from in case someone has been on depot. Remember depot, we have said it's gives you a contraception for 3 months. So in case someone has been on a depot, like we have said for the same for the orals and for the demo, you can insert it at any given time, and you can continue with the contraception. Let's say, for example, the depot is you can use it maybe some like we'll say the depot it takes 3 months. So you can take like 7 days before the expiry of the 3 months. You can insert now the levonorgestrel and use. So in essence, it's like concurrently you're using the 2 hormonal contraceptives until now 7 days after, when now the depot will expire and you continue now with the intrauterine device. I think the main thing in when you're using the Mirena or the levonorgestrel containing intrauterine device is to remember that first you need to rule out if the patient has amenorrhea. Like for example, remember one of the side effects you may get from using progesterone containing is you may get amenorrhea. So first you need to rule out and make sure that the amenorrhea is not due to pregnancy before you even before you start them on the on the progestin containing oral contraceptives. We can go to the next slide. Next, how should we or when should we start after maybe someone has have a miscarriage or abortion? So if it is in the first trimester, you may start immediately after abortion. But if the second to the third trimester, first you want to have involution, complete involution of the uterus. So sometimes you wait for like 4 to 6 weeks. This one helps in helps to even remember these are intrauterine device, and you need them to remain in situ within the uterine cavity. So, but for the first trimester, because the uterus was not that big, involution almost always happened immediately. But for the second and the third trimester, you want to first ensure that we have complete involution, and also you want to ensure, like I've said, there is no pregnancy before you give the progesterone containing intrauterine device. So you don't assume just because someone has had a miscarriage, and they may be within some few months they may have become pregnant again. So you need to rule out that before you start them on the progesterone containing. The next slide, please. Next one. Yes. So this one, it's just a repetition of what you said. You wait for involution of the uterus. Then now you can start the contraception. Next one. Yeah, so these are some of the adverse effects, which are, of course, like we say, they are related to progesterone. So you can have an unscheduled uterine bleeding. You can have decreased bleeding. You can have abdominal pelvic pain. You may have amenorrhea. And remember, we said one of the mechanism of progesterone, it is towards the tubal motility of the cilia. I mean, cilia motility in the tube. So because of that, in case the contraceptive mechanism fails, so it increases the chances of having an ectopic pregnancy as one of the adverse outcomes. In case one fails when they are already on progesterone containing device, there is increased risk of having ectopic pregnancy because of interferent tubal motility. We can go to the next slide. Next one. Next one. Next one. Yeah, so these are all this is what we've been talking about, the side effect of progesterone containing. So for the contraindications, so in case someone has acute pelvic inflammatory disease, you don't want to introduce some foreign bodies. You don't want to introduce something else which may cause more inflammation or may cause even the failure of the contraceptive. And also in case a patient has had endometritis or infected abortion, in case someone has uterine or cervical neoplasm, in case someone was being treated for breast cancer or any other sensitive progestin sensitive cancer, you don't want to use progestin because it is like you'll be adding substrate to the cancer. So in case of any infection, and remember we also say because they are metabolized mostly by the cytochrome in the liver, so in case someone has acute hepatic disease, you want to avoid using them. And also in case the patient had another intrauterine device which has not been removed, you also need not to use another device again. And then in case there is any hypersensitivity to any component of the product, you also need to, that's also an absolute contraindication. And we say the main one contraindication is pregnancy. So it's important to do pregnancy test before you give before you start them on Mirena or any other progesterone containing intrauterine device. So I think I'm done. So welcome the next presenter.
Okay, good afternoon. So I will take you through implants. Kindly go to the next. Contraceptive implants basically are these which we put maybe subdermally so that at least the hormone. Sorry, there is some echo. Okay, thank you. So they are usually inserted under the skin of a woman's arm so that they continue to release the hormone slowly over a period of time. So they don't contain estrogen, so they are therefore very free from most of the side effects which are associated with other hormones. The main mechanism of action basically is to prevent pregnancy by making sure there is enough cervical mucus, which is able to prevent sperm penetration and to suppress ovulation in most of the cycles. They are as effective from as early as 24 hours post-insertion. Next slide. So the types of contraceptives that are mainly used, especially in Kenya, are some of the following. Jadel, which usually contains 2 rods, and mainly the hormone that is there is levonorgestrel, 75 milligram per rod. A duration of effectiveness, usually 5 years. And implanons, usually 1 rod, and it can go up to 3 years. We can also have implant and endoplant as affected above. Some of them may go for 3 years and not necessarily 4 years. Next slide. Yeah, so there are usually two types, those that are containing levonorgestrel and those that contain etonorgestrel. So we go to the next slide. So levonorgestrel is a synthetic and biologically active progestin, and mainly the mechanism of action is production of viscous cervical mucus to impair the penetration of sperm, and also it also inhibits ovulation by acting on the hypothalamus and pituitary gland to suppress the release of luteinizing hormone. Kindly go to the next slide. So Norplan, it's a polymer membrane permission control, as you can see from the picture. It has the crystal inside and controlled by the thin wall silicone tubing to control the release of the hormone. Next slide. So these are some of the rods which are contained in Norplan, 6 of them with 36 milligram of levonorgestrel, and each capsule contains about 34 millimeters long with a diameter of about 2.4. It prevents pregnancy of up to 5 years if you use it properly. Next slide. So Jadel, it consists of 2 implantable rods, as you can see from the picture, 2.5 millimeters in diameter and 43 millimeters in length. Each consists of about a thin wall silicone tubing that controls the release of the hormone, and the core it has about 50% by weight, and which is 75 milligram and 50% elastomer. It prevents pregnancy of up to 5 years, and with the reversible method of contraception, because if you remove it, you can easily regain your periods. So the 2 rods, as you can see, are usually inserted subdermally by injection, and they face toward the upper side or the deltoid region. And so the release per rod is usually at a rate of about 80 microgram per day in the first month and 50 microgram per day in the next 9 months. And then the last will be up to 25 to 30 microgram per day. So the insertion, as we said, usually within the first 5 days or 1 to 5 days of menses. And when you are switching from levonorgestrel intrauterine device implant, it can be inserted after 7 days. So it may also be inserted within 5 days of the first trimester of abortion and second trimester abortion. Next slide. So etonorgestrel, it is synthetic and biologically active. Usually the mechanism of action, as we explained in the previous slides. Next slide, please. So Implanon, it's the only single rod implant that releases the etonorgestrel with for about 3 years, and it becomes effective. It measures about 4 centimeters long and 2 millimeters in diameter. And the core is made of up to 40% ethylene vinyl acetate copolymer, and the other 60% ethynyl vinyl, which is about 68 microgram, and it's surrounded by about 60 micrometers of skin of ethylene vinyl acetate copolymer. So this type of etonorgestrel is released at a rate of up to 70% or 70 microgram per day, and then the next phase will be 35 to 45 microgram per day at the end of the first year, and the following year it will be at a rate of 30 to 40 microgram per day, and then finally release at 25 to 30 microgram per day at the end of the 3rd year. Next. So we go to Nexplanon. It's also a part of the implanons, which we have looked at. They have the same mechanism of action. Only difference is that it has the barium sulfate, which makes it a bit visible when you actually take X-ray or any CT or MRI, so that at least you can be able to locate it. Next slide. So insertion, usually for women preceding hormone use, the implant should be inserted within the first 5 days from the start of the menses. When you are switching from oral, insertion should be done within the first 7 days of the last active pill. So it may be inserted within 5 days of the first trimester of abortion, or within 6 weeks of a second trimester abortion, or within 6 weeks of childbirth. Next. So the advantages of using implants, the contraceptive benefits and also non-contraceptive benefits. So the contraceptive benefits include the fact that it is highly effective and it has a long-term protection against pregnancy. It doesn't interfere with any act of sexual intercourse, and it can be effective from as early as 24 hours. And they don't need to visit a hospital or clinic. And the fertility return is almost immediately after you remove the implants. So the non-contraceptive benefits usually that it doesn't affect breastfeeding and can be used during breastfeeding. It may reduce the menstrual flow, and it helps prevent ectopic pregnancy, although it doesn't eliminate the risk. It protects against iron deficiency anemia, as we've seen from the previous slides. It also protects from symptomatic pelvic inflammatory disease. Next. Yeah, so some of the limitation and side effects are that the client may not be able to initiate or discontinue the method because we need a trained provider to insert and remove. It also doesn't protect against STIs, which can also include hepatitis B, HIV, and the rest. So there may be a delay in resumption of fertility after you removed the implants. Some of the common side effects, which we have looked at in the previous slide, so it's the same. Yes, next slide. Yeah, so this is basically what we've looked at based on the World Health Organization category in terms of whether we should restrict implants implants or use them. So if it is category one, you can use it with no restriction. If it is category 2, you can use if the advantages are generally more than the risk. In category 3, there may be a proven risk which may outweigh the advantages. And if it is in category 4, you can see there are extremely more risk. So it's an acceptable health risk. Next slide. So these are some of the conditions that have been listed to fit in any of these. So you can check it at your own time. Thank you. Yeah. So these are some of those implants which are used in special groups. I think it has been covered elsewhere. But women with HIV or AIDS can use without any restriction. So they are mostly in category 1, as you can see. And other ARV drugs may reduce blood progestin levels, so you can be able to adjust the dose. Efficacy is not that affected, but because the implants provide a consistent dose of hormone over the time, as it's always released at a certain rate. Yeah. Thank you. And the next presenter, please.
Good evening. I'll be taking you through the barrier methods of contraception, which includes the diaphragm, the cervical cup, spermicides, and microbicides and condoms. So the diaphragm is a shallow latex cup with a spring mechanism in its rim that holds it in place in the vagina. And it's normally inserted before intercourse so that the posterior rim fits into the posterior fornix and the anterior rim is placed behind the pubic bone. And then additionally, spermicidal cream is applied to the inside of the dome, which then covers the cervix. And this prevents pregnancy by acting as a barrier to the passage of semen into the cervix. And it can be inserted up to 6 hours prior to intercourse and may be left in place for at least 6 hours post-intercourse. Next slide, please. Yeah, this is some pictures of the diaphragm and how it looks like in situ. Next slide. So the efficacy depends on a number of factors. One, including experience with its use, and then continuity of use, and also the use of spermicide. And the failure rate for perfect use about 6%, and typical use about 12%. Some of the advantages that the diaphragm offers is that the contraception is controlled by the woman, and two, the diaphragm may be placed in anticipation of intercourse. And the disadvantages include prolonged use during multiple acts of intercourse may increase the risk of UTIs, and a poorly fitted diaphragm may cause vaginal erosions. And also diaphragms have a high failure rate, and usage normally requires formal training. The cervical cup is a cup-shaped latex device that fits over the base of the cervix, and a groove along the inner surface, the inner circumference of the rim improve the seal between the inner rim of the cup and the base of the cervix. So the cup must be filled 1/3 full with spermicide as prior to insertion, and it is inserted as long as 8 hours before coitus and can be left for as long as 48 hours post coitus. And it acts as both a mechanical barrier to sperm migration into the cervical canal and also as a chemical agent with the use of spermicide. The efficacy depends on the parity of women due to the shape of the cervical os. Perfect use, the failure rate for nulliparous women is 9% and 20% in parous women. And the failure rate for typical use is 13 to 20% in nulliparous women and 23 to 32% in parous women. The advantages that the cervical cups offers is that one, it provides continuous contraceptive protection from its duration of use, regardless of the number of intercourse acts. And then two, unlike with the diaphragm, additional spermicide is not necessary for repeated intercourse. And the disadvantages include cervical erosion, which may lead to vaginal spotting. It also includes the cervical cup requires professional fitting and training for use, just like the diaphragm, and it has a relatively high failure rate. That's a diagram showing the cervical cup and how it looks like in situ. Yeah, next slide. Okay, these are some of the disadvantages. It also must fit well to be effective, and it is less effective in women who have already given birth. And additionally, it requires periodic checkups, and it offers no protection against sexually transmitted infections and orders and discharges if it is left for too long. So the third one is male condom. Most condoms are usually made from latex rubber, and less commonly polyurethane or the cecum of lambs is used. And the failure rate with strongly motivated couples has been as low as 3 or 4 per 100 couples year of exposure. So it is effective. When used properly, condoms provide considerable but not absolute protection against a broad range of STDs, and they may also prevent and ameliorate the malignant cervical changes, probably by blocking transmission of HPV. And the contraceptive effectiveness of the condom is enhanced appreciably with a reservoir tip. And when you're using lubrication, you should use water-based and not oil-based lubrication because they destroy latex condoms and diaphragms. Next. So for the effectiveness, it must be used as follows. One, it must be used with every coital act. And then two, it should be placed before contact of the penis with the vagina. Three, withdrawal must occur with the penis still erect. And four, the base of the condom must be held during withdrawal. And also either an intravaginal spermicide or a condom lubricated with spermicide should be employed to increase effectiveness. So in case of latex insensitivity, which is common, you can use condoms that are made of polyurethane instead, instead of latex. Next slide. So for the female condom, it has a polyurethane sheath with a flexible polyurethane ring at each end, and the open ring usually remains outside the vagina, while the closed internal ring is fitted under the CPCs like a diaphragm, and the pregnancy rate is higher than with the male condom. Failure rate is about 5% in perfect use and 21% in typical use. So advantages of both male and female condoms is that one, they're easily accessible and affordable, and they highly prevent against STIs and STDs, including HIV. They help prevent premature ejaculation, and they also do not interfere with the sexual intercourse. They are highly effective when used consistently, and they're easy to use. Some of the limitations include a higher failure rate if used inconsistently and incorrectly. And they're user dependent and usually affected by heat, light, humidity, and they cannot be reused, so you only use them once. And for female condoms, they're generally expensive. Next slide. So we'll go to the spermicides and microbicides. So they're usually marketed variously as you can find as spermicidal form, they're contraceptive films. There are others like suppositories, or they may come in the form of spermicidal jelly or creams and gels, and also a contraceptive sponge. Next. So they're useful, especially for women who need temporary protection. For example, during the first week after starting oral contraceptives or while nursing, and most agents can be purchased without a prescription. So they work by providing a physical barrier to sperm penetration, as well as a chemical spermicidal action. So the active ingredient is usually non-oxynol 9 or octooxynol 9 or benzalkonium chloride, depending on the type of spermicide. So an example here is a vaginal contraceptive sponge, which is made of polyurethane impregnated with 1 gram of non-oxynol as a spermicide. So it acts as a surfactant, which either immobilizes or kills sperms. And it releases spermicide during coitus, absorbs ejaculate, and blocks the entrance to the cervical canal. The sponge should not be removed for 6 hours after intercourse. Failure rate is about 32 to 20 in parous women, about 16 to 9 in nulliparous women. Currently, it is observed that non-oxynol 9 is not effective in preventing cervical gonorrhea, chlamydia, or HIV infection. And moreover, it produces lesions in the genital tract, which when used frequently, increases risk of HIV transmission. Thank you. I will welcome the next presenter, Musao.
Okay, my name is Musao. I'm going to take you through IUCD. Next. So IUCD means intrauterine contraceptive device, and it's a commonly used method of long-acting reversible contraception. So there are 2 types of IUDs, which include copper-containing intrauterine device and levonorgestrel releasing IUD. So in the broad mechanism of action, when the uterus is exposed to a foreign body, a sterile inflammatory reaction occurs, which is toxic to the sperm and ova, and therefore impairs the implantation. Also, there's production of cytotoxic peptides and the activation of enzymes that leads to inhibition of sperm motility, reduced sperm capacitation and survival, and also leads to sperm phagocytosis. Next. So the copper intrauterine contraceptive device is a T-shaped device that is wrapped in a copper wire that is inserted into the uterus. And it contains 380 square millimeters of copper. And it's approved for 10 years of continuous use and may be effective for longer. So the mechanism of action, copper enhances the cytotoxic inflammatory response within the endometrium, and therefore impairing sperm migration, viability, and also impairs implantation. Next. So indications for the copper IUCD, it can be used for emergency contraception. It's considered the most effective type. It can be inserted within 5 days of unprotected intercourse, and as low as less than 0.1% pregnancy rate. Can also be used as a patient who is considering a long-acting contraception, and also is used in contraception in patients with contraindications for hormonal-based contraceptives. The efficacy is with perfect use, the probability of pregnancy in the first year is about 0.6%. However, women that are under age of 25 experience a slightly higher failure rate, mostly most likely because they are more fertile than the older women. And as I said, it can be effective for 10 years. So contraindications for using copper IUCD include uterine abnormalities such as bleeding, malignancy, infections, and abnormal anatomy, cervical infections, pregnancy, menorrhagia, dysmenorrhea, and copper hypersensitivity. So it also has non-contraceptive benefits, including continued menstrual cyclicity because it's non-hormonal, reduced risk of cervical, and also reduced risk of endometrial CA. Next. So next. Yeah, levonorgestrel releasing IUDs are also T-shaped devices that now produce or release levonorgestrel. And the mechanism of action is that progestin thickens cervical mucus, which acts as a barrier to the upper genital tract, causing endometrial destigmalization and glandular atrophy that impairs implantation and may also inhibit the binding of the sperm and egg by increasing glycodyl egg production. So there are three types. There's a 52 milligrams levonorgestrel IUD that has an initial release rate of about 20 micrograms per day. It declines to an average release of 10 micrograms per day at 5 years. And it is approved for 6 years as commercial names of Mirena and Theta. And then there is a 19.5 levonorgestrel IUD that has an initial release rate of 17.5 micrograms per day. It declines to 7.4 at 5 years, and it's approved for 5 years. Commercial name is Kylina. Then the 13.5 milligrams levonorgestrel IUD, which has an initial release rate of 14 micrograms per day, which declines to 5 at 3 years and is approved for 3 years of use. So next. These are just diagrams of the same. So the non-contraceptive benefits of the 52 milligram include it reduces heavy menstrual bleeding, reduces the chances of anemia, dysmenorrhea, endometriosis-related pain, endometrial hyperplasia, PID, and cervical cancer. Next. So in the selection of intrauterine devices, the reasons or advantages of choosing a copper IUD as compared to the hormonal one, it's that some of the advantages include avoidance of exogenous hormones, continuation use of IUD building pattern because it's non-hormonal, a desire for long-term contraception, whereby the copper one is approved for 10 years, which is longer than the hormonal ones, and then a need for emergency contraception. So as I said before, it can be used for emergency contraception and then left in place to continue providing ongoing contraception. So the advantages of levonorgestrel releasing IUD include a reduction of menstrual bleeding and therefore a reduction in chances of getting anemia. They can cause a possible amenorrhea, a reduction in dysmenorrhea, and also a treatment of endometriosis-related pain. So next. So in the timing of insertion, IUDs can be inserted anytime during the menstrual cycle. Pregnancy can be reasonably excluded. And timing of insertion with menses ensures that the patient is not pregnant, but does not reduce the pain or improve the patient outcomes during menses. So usually the documentation of negative pregnancy tests prior to insertion of the device is advised, especially in patients with lactation or amenorrhea with regular intervals. So always the pregnancy test should be obtained 2 or more weeks after her last episode of unprotected intercourse, and also screening for gonorrhea and chlamydia to all women presenting for IUD insertion, regardless of the risk factors, can be performed at the time of the insertion. So post-abortion, the IUD can be inserted immediately, and then postpartum now, depending on the time in which it's inserted. So it can be immediate post-placental, that is within 10 minutes after delivery of the placenta, following delivery. It can be early delayed, between 10 minutes and 1 week after delivery, or late delayed, insertion at intervals of a few weeks postpartum, but less than 6 weeks, or interval postpartum insertion, that is the insertion 6 weeks or beyond after delivery. So when the patients want to switch from IUD to another contraceptive method, the copper one is usually immediately effective upon insertion. As women who choose copper IUD do not require any backup contraception regardless of the prior method of contraception. This is in contrast next to the levonorgestrel releasing IUD, whereby it is thought that women who select this one may be at risk of unplanned pregnancy in the first week after the IUD insertion because of hormonal IUDs are potentially not immediately effective. So after inserting these IUD devices, patients should be provided with post-insertion counseling. They should be advised on the side effects that they should anticipate, such as fever, worsening pelvic pain, abdominal pain, syncope, sometimes unusually heavy vaginal bleeding, suspected expulsion, false-smelling vaginal discharge, or pregnancy-like symptoms. So they should also be counseled about backup contraception to avoid unplanned pregnancies, especially for the ones who are using the hormonal IUD. And then they should also be taught about self-IUD string check, whereby if she cannot fill the string, she should use a backup method of contraception until she can be examined by her clinician to confirm whether the IUD is in place. Then they should be advised also to come for follow-up visits in 1 to 3 months. Considering concerning IUD removal, they can be removed by the clinician anytime a patient desires pregnancy or becomes dissatisfied with the method. Otherwise, they can be removed at the end of its duration, specified by the device package insert. So they can be removed anytime during the menstrual cycle, and women should be informed that fertility can return immediately, so they are at risk of getting pregnant. So removal is accomplished by grasping the strings with long Kelly forceps, also called Bosman forceps, ring forceps, or similar instruments, and gently pulling the IUD out in one swift maneuver. And then it's usually good to examine the IUD to ensure that it is complete, or it is removed intact. So some of the complications that are associated with intrauterine devices, you can divide them in several groups. So complications that are associated with insertion include difficulty insertion that can be uncomfortable for the patient, vasovagal reactions such as syncope, presyncope, nausea, bradycardia, hypotension. However, these are most transient and resolved spontaneously. Also, unexpected findings at the time of placement, whereby you can get large or small uterine cavity or infection, and therefore interfering with the normal insertion procedure. Also, there can be perforation leading to pelvic pain and also active bleeding from the cervical pulse. So immediate post-insertion complications are the ones which happen between 0 to 7 days, and they include post-insertion bleeding, uterine cramping or pain, and infection for the PID, that is pelvic inflammatory disease. And then early post-insertion complications, that's the ones that can occur between 0 to 3 months, include irregular bleeding or cramping, and problems noted at the time of follow-up examination, such as unpalpable strings, invisible strings, or expulsion of the device. And then there is complications that can occur anytime, such as a malpositioned IUD, expulsion, pregnancy complications. IUD are one of the known risk factors for developing ectopic pregnancy, and also if intrauterine now there are risks they can cause to the pregnancy, like chorionitis, miscarriage, preterm labor, and placenta abruption. And then hormonal side effects, usually related to progestin, and include acne, weight change, hirsutism, headache, nausea, and mood change. Then there are issues and complications at the time of removal, such as non-visualized string, difficulty removal, or broken devices. So some of the benefits of IUDs generally include they are highly effective. They are highly effective in the pregnancy prevention with more than 99% efficacy. And they do not require regular adherence from the user to maintain high effectiveness. They are long acting and they are reversible as well. And they have few medical contraindications for most women, including teens and nulliparous women. And then you can avoid use of exogenous estrogen in both types and hormones in the core power. And then they are in long-term use, they have a reduced cost because it's only once in a long time. And then there's reduced risk of cervical, endometrial, and ovarian cancers. Next, thank you.
Excuse me, Zaid, we can't hear you. We can't hear you clearly.
Now,
Okay, so I think I'll carry on if everyone can get me. Data that was collected some years back in the US showed that about 5.7% of men between 15 to 44 years had used vasectomy, which now makes it the fourth most commonly used contraceptive method after, of course, condoms, oral contraceptives, and tubal ligation. So, of the specialists who carry out this procedure, it's mainly done by urologists, which according to the study, it had been shown that 79% of these vasectomies in the US are done by urologists. Then family physicians do 13% of them, and then general surgeons do 8% of them. And then the cost of these vasectomies is between thought to be between $350 to $1,000, which is which when you compare to those other methods, it becomes cheaper as compared to those other long-term pharmacological contraception or sterilization procedures. It's very effective with reports showing that it's about 98% effective. So when you want to do that procedure, so there's the preoperative preparation of the patient, so management of the patient preoperatively. Then I'll talk about the procedure, what is done during the procedure, and then postoperatively what will be done and the complications. So preoperative management. So you need to take a very careful medical history. You should assess for abnormalities in sexual development, and then any history of genital injury or surgery. Then you want to do a complete joint examination. You want to ensure that there are no anatomic abnormalities. So you want to ensure that there is a single vas difference on the testicle on each side, and there is no any anatomic abnormality. Is as I had mentioned earlier, it's performed as an outpatient procedure under local anesthesia. So there's a selection of so there are two procedures that can be done, two options. There's the conventional method where there's an incision on the scrotum made, and then there's now that the transection of the vas deferens, while the other option is now the non having some connectivity issues. I hope you can still get me. So as I was saying, the other method is a puncture site where you don't use a scalpel. In both these methods, the vas is in the scrotal skin incision method. You saw there's an incision made in the scrotum, and then in the scrotal skin, then the vas difference is transected, and then a segment of it is removed, and then there's a fulguration, and that is use of diathermy to make sure that the prostatic end of that vas is blocked, and then the testicular end. There are various there are different ways of handling the testicular end. The most ideal way of handling the testicular end of the vas is now a fascial interposition, which isolates the vasovasal ends from each other. The other method, the no-scalpel approach, is the most preferable one because it has lower bleeding and lower infection rates. So there's identification of the vas deferens simultaneously to make sure that both of them are present. There's no anatomical abnormality. Then there's injection of an anesthetic is made over the vas. Then the needle is positioned to isolate the vas from the surrounding tissue, and then there's the clamping, and then a segment of the vas is removed, and then the remaining ends can be tied, or the other option is you use diathermy on the prostatic end, and then you do a fascial interposition to prevent to Okay, so the following image is just an image of the no scalpel vasectomy. Basically, it's like a minimal invasive surgery, as you can see, but basically still there's the ligation of the tying and clamping of a segment of the vas. And then, so postoperative care includes scrotal support, application of ice intermittently, and rest. Then the person can resume sexual activity after at least a week. And however, they need to have an alternative method of contraception until they can do seminal to ensure that there's azoospermia. So complications that you expect include, so intraoperatively, some complications include formation of a hematoma. Then there can be surgical damage to the spermatical vessels, which will compromise the testes and even result in atrophy. Then there can be neural damage that can result in either immediate pain or pain that is persistent and chronic. Postoperatively, you can have hematomas or wound infections. Then there can be epididymal congestion, and then also there can be formation of a sperm granuloma. So a patient who has sperm granuloma will come to you and they'll tell you they have a lump. That's basically just the sperms that have been extravasated. They accumulate and kind of, there's a formation of a lump over time. Which is a sperm granuloma. So for those when you're talking to a patient, your patient may be worried. In our setup, people don't really do vasectomy. So if your patient is worried about the effects of vasectomy and it being a permanent method, and they feel like they might never have another opportunity to have kids, you tell them vasectomy can be reversed with microsurgical techniques. So it's just basically anastomosis of the reproductive tract, and I think it's quite successful vasectomy. It's about it's quite, the success rate is high of reversal, and this person attaining fertility again. So they shouldn't be worried that it's totally like it's once they have it, that's it forever. So indications of vasectomy include a person who doesn't want to have any children, or if they have children or they don't have any addition, they don't need any additional children, and they're willing to have that, that's an indication. But then contraindications include the anatomic abnormalities. That's why I said in history and your examination, you have to rule out any abnormalities of the vas deferens. They have to be really to be intact, and there's no anatomic abnormalities. You also want to rule out that there are no large hydrocele or varicoceles. And then another contraindication is if there's any past trauma or scarring of the scrotum or acute local scrotal skin infections, you may need to you may not, it's not advised that you do a vasectomy. So advantages, it's a permanent method of contraception. Yeah, so with only so I think if our setup is not quite, it hasn't really picked up well in our setup, but as more and more people become enlightened, I think it will become a trend in the near future as more and more people decide to control the number of children they like to have. So before I welcome the next presenter, let me just allow me just a minute to see if I can adjust these slides a bit to, yes. So Amban, you can take over.
Okay, thank you. I'll be taking you through tubal ligation. Next slide. So tubal ligation is a surgical procedure that involves cutting, sealing, or blocking of the fallopian tubes. And it can be achieved through mini laparotomy, laparoscopically. The principle being that you want to prevent the fertilization of oocytes and also prevent the transport to the uterus. So it's a permanent method, despite there being a means of reversal. The success rate of the reversal is at about 2/3. So most of the people, once you've undergone tubal ligation, you're supposed to treat it as a permanent method, and that's the advice you're supposed to give the patients. Next. So this just shows you the various methods. You can tie and cut, you can cauterize, and you can band. Next. So the advantages is that it's very effective. It has a very low failure rate. It's a permanent method. Then, unlike most of the others, it's a single procedure that leads to the lifelong safe and very effective family planning. The patient does not need any other supplies. They do not need to make several clinic visits once the immediate post-surgical follow-up has been done. Then it does not interfere with sex or the woman's ability to have it or to enjoy it. Then there are no known long-term side effects or health risks. Next slide. So the disadvantages, I'll summarize them as complications, which can be complications due to the surgery and then complication due to the anesthesia. These are brought out in detail later, so just proceed. So there are various times that you can decide to do the tubal ligation. The first one being intrapartum during a cesarean section. Then you can do post-abortion, that's at least within 48 hours. Postpartum within 7 days. So for this, mainly the oviducts are usually accessible to the umbilicus directly beneath the abdominal wall during this postpartum period. Remember, the uterus is still trying to go back to its prepartum, pre-pregnancy state. So you can be able to access the oviducts at the umbilicus level. Then we have the interval procedure that is unrelated to pregnancy, which means now you will not be doing the mini lab procedure, but it will be a full surgical procedure. And then we have the other time that you can do it when you're doing another surgery in the abdomen. Next. So a few things that you need to establish before you decide to undertake bilateral tubal ligation. You need to rule out that the patient may be pregnant. You need to rule out infections or other problems with the female, and if possible, treat them first. Then you also want to consider if they have serious medical systemic conditions such as hypertension, stroke, heart diseases, or severe anemia, which you might handle before the procedure, or if you indeed decide to go ahead with the procedure, then you need to do several considerations in terms of the anesthesia. Okay, proceed. So one thing to note about the case selection is that you should be able to do this procedure as soon as or whenever the woman wants to have the procedure. Otherwise, it's good for the following people. So the client should at least be married, including if they've ever been married at some point in their life. And this is because most of the clients who come and ask for reversal letter is when now, let's say they made this decision before they got married, and they decide maybe they're under spousal pressure, they decide they want a child, so they'll come seeking for reversal. Then the female client should be above the age of 22 years and below the age of 49 years for obvious reasons. Then the couple should have at least one child whose age is above 1 year. Then the clients or their spouses should not have undergone a sterilization procedure. That's that one, the one that they presented, vasectomy in the past. The clients must be in a sound state of mind so as to understand the full implication of the sterilization. And if they have a history of mental illness, then their decision should be certified by a psychiatrist. So as I'd say that if an unmarried or a woman who has no children comes and tells you they want to do tubal sterilization as their preferred method of contraception, it should not be denied them. And then something else to note is that the consent of the spouse is not necessary. So these are medical conditions. You can proceed. Yes, these are the medical conditions that if a patient has them, then you might need to ensure that the procedure is being done in a hospital that is able to handle any complications. These are patients with cardiovascular diseases, hypertension, diabetes, hyperthyroidism, etc., etc. The ones I had mentioned. Okay, proceed. So you need to just counsel the patient before you do the procedure. You need to tell them that it's permanent. You need to tell them that since it's a surgical procedure, it has its complications, it might fail, and it might require further management. Tell them that it does not affect sexual ability, pleasure, or performance. They need to know that it does not protect them against STIs or HIV, and tell them that the reversal of the procedure is possible, but it's a major surgery, and that its success cannot be guaranteed. So we'll start with the Pomeroy technique of tubal ligation. This is the common, rather the most frequent method used, and it involves tying a suture around the segment of the tube and then cutting the segment and removing it. It's the most performed. It's mostly performed after cesarean delivery, and it ends with two healthy segments of the fallopian tube that can be reanastomosed in case reversal of the surgery is desired. Then, so the amount of tube that is removed will determine the reversibility of the procedure, and it also determine the chances of the method failing as a method of contraception. Let's continue. Okay, for this one, we'll see several photos later. We have various variations of the Pomeroy tubal ligation technique. And then we have, okay, I think I've covered most of everything in this slide. Yes, proceed. So approximately 2/3 of women who have had approximately 2/3 of women who have had Pomeroy tubal ligation are able to become pregnant after reversal of the surgery. As you had said, the location of the cut, rather the location of the excision will determine its reversibility. Let's proceed. So you make a 3 centimeter suprapubic incision, but I've seen around here we were making just beneath the umbilicus for the Minilla procedure. So after we made the incision, you locate the oviducts, and then use an absorbable ligature around the base of the elevated segment. You cut out the 2 sides of the elevated segment, and then you remove those parts and return the other segments separated back into the abdomen. So this is the group of people who are able to do it. You should be able to do it during your internship under supervision. Medical officers are expected to know it, and registrars and specialists. Proceed. So this is just a step-by-step image showing the procedure, so that you can be able to see it. And then remember, it has a failure rate of 300 to 500. Okay, I've covered this data. Then now we have another variation. This is called the Parkland technique. So in the Parkland technique, you first start by separating an avascular area in the mesosalpinx beneath the tube. And then once you've separated the area, you free about 1 to 2 centimeters of the tube. This one has a failure rate of about 1 in 400. Next. With the Chida technique, you first start by injecting a saline solution into the mesosalpinx. Then the saline solution is able to separate the serosa from the tube, and then you ligate and resect 5 centimeters of the segment. And then once you've done the resection, you reapproximate the serosal edges, and then the proximal tube is then buried within the broad ligament, as you can see in the diagram there. Then iving technique, this one is also designed to be used during the cesarean time. So for this method as well, you ligate both sides of the tube, and then you remove the central part. And then now the stumps, now you bury the stumps separately. You bury the proximal end back into the myometrium, and the distal end, the one at the fimbria end, you bury it back into the mesosalpinx. This one has a failure rate of 1 in 1,000. So as you can see, it's the one with the best odds here. Then you have the carotid fimbriectomy technique. So this one, the ligation and excision is done at the fimbriated end. And this one has the highest failure rate, as the tubes are known to recanalize. And okay, you're moving slightly faster there. Can you just go back a little so that I finish on the, yes, that one. Okay, so usually when you've done fimbriectomy at the far end, the tubes can recanalize as well. And then there is reuptake of the released ovum and high risk of failure of the procedure. Then you can go to the next one now. So the next one is called the Madlena technique. So this one, just like the Pomeroy, you ligate both sides of the oviducts, but now in this case you're using an absorbable suture. And then instead of cutting, doing an excision and removing a portion of the oviduct, you only crush it with a forceps, and then you leave it in there. So it has a very high failure rate, and it's only taught to discourage its use. So don't use it. Next. So there are various instances of regret after sterilization. I have about 7% of women undergoing sterilization expressing regret within 7 years. And the reasons why they do this are one, that they were at a very young age at the time of sterilization. And then they had a change in marital status, just as I had said earlier. Proceed. Then independent predictors of increased risk of having complications during and after the procedure have diabetes, patients with diabetes, complications related to the anesthesia, and then patients who have had a previous abdominal or pelvic surgery, and patients who have obesity. Proceed. Okay, another method of doing the tubal ligation, or rather the sterilization, is use electrodesiccation, where I use the bipolar to sterilize the patient. There's a high risk of fistula forming, and then another risk of ectopic pregnancy. Then one of the biggest side effects is hematosalpinx. Next. We can also use rings. So in this case, we use what's called the fallope ring. So the ring is inserted, is milked over, or rather inserted onto the oviducts, and it has a high risk of mesosalpinx hemorrhage and laceration of the tube. I can also use a clip. We have this clip called the Filshie clip, made of titanium with a rubber lining. So the clip occludes the lumen by pressure, and then once necrosis sets in and the tube starts to reduce in size, the rubber expands to maintain the blockage that you had. So it has a failure rate of about 7 in 1,000. Then you have various clips. Here there's the Hulka clip that is toothed, and it's usually applied at right angles. So most of these procedures are usually done laparoscopically. Rather, laparoscopy is the method of choice. Okay, proceed. And then we have a hysteroscopic approach. So maybe we'll also get a little insight on this. We have the Essure micro inserts, which work by the principle. They're made up of nickel, titanium, and steel. So these inserts are inserted into the oviduct through the vagina and uterus, and then once they're there, they work by causing inflammation and fibrosis, which result in a gradual blockage of the fallopian tubes. It can be performed under local anesthesia. It's cheap and efficient. Let's look at its picture so that people can orient themselves a bit. Next. Yeah, so you can see the tube is getting into the oviduct. Then once the stent is left there, some inflammation and fibrosis takes place, and over time we have full blockage of the oviduct. Okay. The vaginal approach has been associated with the high risk of pelvic infections and hemorrhage, so it has lost popularity with onset of these laparoscopic surgeries. The other risks for these are hydrosalpinx, menstrual cramps, dysmenorrhea, and dyspareunia. And it has a failure rate of 1.17%, so it's obsolete at the moment. Then postoperative instructions, you should instruct the patient 2 to 3 days, avoid sex for at least a week, and avoid heavy lifting for a week as well. The client must be seen within 48 hours. Then you can organize for a second follow-up, at least the 7th day post stitches, and just checking the wound site. Then a pelvic examination can be done if indicated. Then third follow-up can be done 1 month after the client's first menstrual period, whichever comes first. And then you need to tell the client about danger signs that once they see them, they should return. That is, if they miss their periods, they have pain, swelling, fever, or any other complaints. So the complications are divided into intra-op complications and post-op. So under intra-op, we have nausea and vomiting, vasovagal attack, respiratory depression, cardiovascular, perforation of the uterus, vascular injury, injury to the urinary bladder, ureters, injury to the intra-abdominal viscera, then convulsions and toxic reaction to the anesthesia. Next. Postoperative complications, we have wound sepsis, hematoma in the abdominal wall, intestinal obstruction, tetanus, incisional hernia, or patient regret. Proceed. Okay, thank you.
Okay, good evening. I'll take you through natural family planning methods, and we'll start with the lactational amenorrhea. So during lactation, you have a suppression of ovulation. This is due to the elevated prolactin levels and the reduction of gonadotropin releasing hormone, which has an effect on, it causes reduction of the luteinizing hormone release and also inhibits follicular maturation. So the duration of this suppression varies, and it is influenced by the frequency and duration of the breastfeeding and the length of time since birth. So for perfect use, the method requires exclusive breastfeeding of the baby. There's Also, when there is no return to menses, and the baby must be younger than 6 months for perfect use. Next. So the advantages of lactational amenorrhea is we have there's return to fertility is immediate once you stop exclusive breastfeeding. Also, it is provided and controlled by the mother. It also requires no supplies or procedural, hence economical, has no hormonal or any severe side effect, and also it supports and promotes infant feeding for exclusive breastfeeding, which have health benefits for the baby. Next. The limitation that is there is the breastfeeding can transmit HIV from mother to child, and also exclusive breastfeeding may be inconvenient or difficult for some women, especially working mothers or women on some medications such as lithium. Next, another natural method that we have is coitus interrupters or withdrawal. Coitus interrupters involves withdrawal of the entire penis from the vagina before ejaculation. So fertilization is prevented by lack of contact between spermatozoa and the ovum. The failure rate is approximated to 22%. Next. Advantages is it is available, it is immediately available. There's no devices used. There's no cost, and there's no chemical involvement. The disadvantages is that it needs self-control and a precise sense of timing to be able to withdraw. And then the probability of pregnancy is high with incorrect or inconsistent use. Next. Then you have the rhythm method. This is based on identification of the fertile period of a cycle and helps to abstain from sexual intercourse during that period. So the methods to determine the approximate time of ovulation and the fertile period include a temperature rhythm, we have the calendar rhythm, and then we have the mucus rhythm. Next. So for the temperature rhythm, this is the end of the fertile period is predicted by measuring the basal body temperature. And the basal body temperature of a woman is relatively low during the follicular phase and rises in the luteal phase of the menstrual cycle in response to the thermogenic effect of progesterone. So the rise in temperature can vary from 0.2 to 0.5 degrees Celsius, and the elevated temperatures begin 1 to 2 days after ovulation and corresponds to the rising level of progesterone. So intercourse can resume 3 days after the temperature rise. Next. On mucus rhythm. So for the characteristic of the cervical secretion, it is mostly affected by the estrogen and progesterone concentration. So the woman attempts to predict her fertile period by quantifying the cervical mucus with her fingers. So during ovulation, the mucus is mostly clear, wet, and stretchy. That is before, during, and immediately after ovulation. This is followed by scant and dry mucus secondary to the influence of progesterone, which remains until the onset of the next menses. The intercourse is allowed 4 days after the maximal cervical mucus until menstruation. Next. Then have the calendar method. So the menses is so a woman is required to record her menses for 6 cycles or even 4 cycles to approximate the fertile period. So for you to calculate the first fertile day, you find the shortest cycle in your past record. If you've recorded for 4 cycles or 6 cycles, so you find the shortest cycle, then you subtract 18 from the total number of the days in that cycle. Now, so you find your first fertile day. For your latest fertile day, you find the longest cycle in your record. You subtract 11 from the total number of days in that cycle, and then you get the last fertile day in your current cycle. Next, so those you'll get your fertile days. That is when you avoid to have sex at that period. So the advantages, yeah, there is no cost and lacks side effects. Disadvantages, it's difficult to calculate the safe period reliably, but we have applications that you can get at your Play stores that helps you to calculate this. compulsory abstinence from sexual acts during the certain periods, and then the not applicable when the periods are irregular, and failure rate is 20%. Thank you. I welcome the next presenter.
My name is Aisha Mahmoud, and I will take you through contraception for special groups. So, family planning services for special group require extra attention from healthcare providers. They include the adolescents and the youth, the men living with people living with disabilities, mobile population, and person living in informal settlements and humanitarian settings. Next slide, please. So the principles for provision of adolescent and youth-friendly services include showing young people that you enjoy working with them, offering services that are free or as low cost as possible, offer a wide range of contraceptive methods, including long-acting reversible methods, ensuring confidentiality and assure the clients of confidentiality, listening carefully and ask open-ended questions such as how can I help you and what questions do you have, use simple language and avoid medical terms, use terms that suit young people, and avoid such terms as family planning, which may seem irrelevant to those who are not married. Welcoming partners and include them in counseling if the client desires. Next slide, please. So you try to make sure that a young woman's choices are of her own and are not pressured by her partner or her family. In particular, if she's being pressured to have sex, you help a young woman think about what she can say and do not resist and do to resist and reduce that pressure. So you practice with her the skills to negotiate condom use, and you speak without expressing judgment. For example, say you can rather than you should. Do not criticize even if you do not approve of what the young person is saying or doing. Help the young clients make decisions that are in their best interest, and take time to fully address questions, fears, and misinformation about sex, STIs, and contraceptives. Many young people want reassurance that the changes in their bodies and their feelings are normal. So you be prepared to answer common questions about puberty, monthly bleeding, masturbation, nighttime ejaculation, and genital hygiene. Next slide. So you'll be aware of the young people's norms about gender and gently encourage positive, healthful norms. In particular, you can help young women feel that they have the right and the power to make their own decision about sex and contraception. You can help young men to understand the consequences of their sexual behavior for themselves and their partners. And as for the unmarried young people, they may have more sex partners than their older people, and so may face a greater risk of STI. It is important when counseling young people to consider STI risk and how to reduce it. So for the men, they usually, they influence women, and many men care about their partner's reproductive health and support them. So we have others that stand in their way to make decisions for them. Thus, men's attitude can determine whether women can practice healthy behaviors. You should encourage joint decision making about sexual and reproductive health matters, which include family planning method both for men and women, including safety and effectiveness. STI, including HIV, how they are and are not transmitted, the signs and symptoms, testing and treatment. Then the benefits of waiting until the youngest child is at least 2 years old before a woman becomes pregnant again, and male and female sexual and reproductive anatomy and function. You should educate them about the anatomy, including helping any sexual problems they may be facing, as well as safe pregnancy and delivery. You should as well educate them on, you should as well counsel them on infertility and screening for penile and testicular and prostate cancer. So for the mobile population, include irregular immigration status. They will as well have language barriers. They can lack of migrant inclusive health policies, and inaccessibility of services due to inopportune operation hours. So for the guidelines include, you should first ensure privacy and confidentiality, right to all forms, including emergency contraceptive, then dual contraception, proper referral services, and prompt medical attention to sexual violence victims. Next slide. So family planning services for people living with HIV and AIDS. So these people have a right to family planning just as they're non-infected people, as if family planning is a co-intervention of prevention of mother-to-child transmission. So the service provider should adhere to the eligibility criteria for the different family planning methods. So I'm welcoming the next presenter. Thank you.
Hello, good evening. So John Maure, I'll present on contraceptive emergency, and I think this should be our last part of our presentation. So as the name goes, emergency contraceptive is a form of contraception which is used after intercourse, but before implantation, or rather before the establishment of pregnancy. It is also known as a postcoital contraception. So it does, of note, it does not interrupt an existing pregnancy, but rather it just presents the establishment of pregnancy. So there is no effect. It doesn't have an effect on abortive effect. Some of the indications that the indications for emergency contraceptive is when you have unprotected intercourse or failure of barrier methods. For example, if you used maybe a condom and then it failed, or maybe you have a missed contraception, like you've not taken your pills or injectables, or maybe you have a forceful intercourse, especially during rape. So some of the methods of emergency contraceptions that we'll consider are oral methods, and also the intrauterine devices methods, which includes the copper IUD. We'll talk as we go on. So some of the oral methods that are used, we have the common one used actually is the P2. We can also have the ELA. We can also have mifepristone and use that method. So for the P2, it disrupts ovulation and copper solution function. So it's given as it comes as a single dose of 1.5 tablets to which protects up to 72 hours post intercourse. So for the ally, it goes up to 120 hours post intercourse. So you take 30 milligrams within 120 hours of post intercourse. The other one is mifepristone, which binds competitively to progesterone receptors to nullify the effects of endogenous progesterone. So it also comes as a single dose of 100 milligrams. It's taken within 17 days of intercourse. The use method, it's a combine both the oral estrogen and progesterone derivative contraceptive pill. So the next one is a diagram of just shows the interaction of the anatomy of the female reproductive part, and where those interactions of the different family planning methods that we've already covered actually. So it's just a broader diagram giving the sites and the interaction and what happens. So you remember the second part is the intrauterine devices. So we've talked of the oral. So now we will deal with the intrauterine devices. The common one is the copper IUD, which is inserted up to 5 days after intercourse. So this one prevents implantation by possibly disruption of sperm and ovum function or alteration of uterine physiology. So it's more effective than the oral methods with pregnancy risk of 0.1%, can continue to provide effective long-term contraception. So some of the contraindications of these barrier methods is if you have a pelvic infection, suspected pregnancy, unexplained PV bleeding, malignant, especially the trophoblastic diseases, then endometrial or cervical cancer, uterine anomalies or distortion. So some of the side effects that comes with these contraceptions are pain, bleeding, expulsion, and pelvic pain. Of note is that the barrier and non-hormonal contraception can be used immediately after the emergency contraceptive use, there is no period of abstinence that is required. For the hormonal contraception, it requires abstinence or backup contraception for about 1 week. So emergency contraceptive use without menses in the next 3 weeks warrants a pregnancy test. I think that should be my last slides. Thank you very much for the attention. Sorry, we've taken, I think, much time. Maybe I'll invoke Daktari's up to this point, with Daktari's input.
Thank you very much for the presentation. I think this is one of the longest presentations I've attended to. I'm very much agreeable with the content. My only wish is that you guys understand what you are talking about. It's easier to recite, but I think we need to ensure that whatever is being presented can be integrated. I think it's just worth to mention a few points. One, the reason why we discuss family planning all over the world, you guys are aware of social development goals, millennium development goals. People are looking for a way of reducing maternal mortality, but clearly it's come out that the best way to reduce maternal mortality is across the world, especially in sub-Saharan Africa, is through family planning. And the contraception is the means through which we, will do family planning. So from literature, it's thought that if we practice family planning and if we reduce the unmet need of family planning, like one of the presenters said, we will reduce maternal mortalities by up to 30%. What that means in this country, for instance, for those of you who don't know, in Kenya, every day, a minimum of an average of 21 women die every day, which literally translates to 1 woman per hour is dying in this country due to pregnancy-related complications. So if I have to emphasize anything, is that family planning is not just the wish of the doctor, it's the wish of the world, that a woman has planned pregnancy. And unplanned pregnancies are the cause of unwanted pregnancies, and at the same time, the reason behind abortions, or rather pregnancy wastage. So this is very important to emphasize, and probably is the reason why we've sat here the whole afternoon. And also to mention that, we're not so many as a country, but the most important bit of our population is growth. It's the population rate. For instance, a land like Uganda, the population is around 44 million, but the whole country is Arab. We've got 3 or 4 times mass of a country, which is fairly not useful. Because, you have to, that's why we have to cry that we need donors to help us because we are dying from hunger. So it's also a very important tool for economic planning. I agree with the content, and the other thing that I need to emphasize is the medical eligibility criteria. The presenter did very well. He presented the basis for medical eligibility criteria. And before I received these slides, I expected that for every method mentioned, the presenter ensures that you put at least a comment of medical eligibility criteria for the various conditions. This is the reason behind why a doctor discusses family planning. Otherwise, family planning is a widely task shared function. As you might realize, we're doing family planning is being run by nurses, even here in MTRH. But the idea really should be for chronic medical conditions, especially when we talk about hypertension, diabetes, SLE, GTD, all those kinds of diseases. Then as a doctor, you come in, even the nurse gets into the very end. So there's also a reason why we have to teach you family planning. And the most important thing is to know when a method is applicable and when a method is not applicable. So I believe that all of us will do that bit. The next comment I want to make is on the various methods, especially they present on triple ligation. Is it triple ligation? I'm a permanent methods. That's vasectomy and PTL. For vasectomy, I think it's the only male method. So we give it the importance it deserves. As you have heard, and like our men who even our women will resist that we do not undergo vasectomy. In the US and in North America generally, by the year 2000, over 4 million men had been vasectomized. Maybe we need to do that exchange program a bit so that we get our men also undergoing vasectomy. It's also worth it that men develop interest, and even we ourselves develop interest in vasectomy, because it's rarely used. The skill is also wanted. On permanent contraception, this is very important. There is a time the whole world was cycling towards permanent contraception, especially for the African population, until it created scandals in this country. But there has been a shift from this. And this is because we now have what we call long-acting reversible contraception. And one of the methods is IUCD, which can be used for up to 10 years, depending on the type. And implants. And on this basis, we have developed a very good protocol in Mat and Pepe, and this is to do with the contraceptive choices for women in the immediate postpartum period. And here we are emphasizing on long-acting reversible contraceptions. If I have to mention IUD and implants. But when you look at literature on permanent contraception, especially triple ligation, the methods presented are good. The common ones change of direction, which things are taken. So salpingectomy, meaning that the tubes, if left, if of ovarian cancer. And but it's good that as surgeons, as doctors, you know the historical and the use of the methods. The other very important aspect that I want to emphasize is the whole issue of the PAR index, which is a demonstration of the effectiveness of the methods using an index. In other words, in simpler terms, is failure rate when used in research, and the failure rate when used in a normal day. Because in a normal day, there is forgetfulness, there are all kinds, there is myths, there is all kinds of discouragement. and therefore the method is not so used in a perfect way. So the failure rate in a normal day is higher compared to the perfect use. The perfect use is like a research kind of setup. So the most effective contraception is the implant, and followed by some, IUCD, vasectomy. Somebody presented this here. So you guys need to know that the effectiveness of the method is used as a way of counseling the women. As you remember, the presenter on natural method said most of the methods have got a 20 to 28% failure rate. What does this mean? If you are going to fail 28%, for example, telling a man to stop having sex, at that time is at the climax of it, and say, you withdraw and ejaculate outside. It doesn't apply to every man. Some people have got issues. Some are premature kind of ejaculators. Others have got, issues of, how do I call it? They have got disorders of sexual, disorders of sex. And therefore, it's difficult because it depends. There are times even women will not want that man to come out as a result of, depending on the reason for sex. If sex is for pleasure, if sex is for procreation, all that have got different kind of approaches from the participants. And then, emergency contraception, I think I did not hear, okay, the presenter gave the
Sorry, you've lost Dr.
methods of emergency contraception. The most effective method is basically IUD. And I do believe that that's why the whole world has done a refocus on contraception, even for, people who used to believe in contraception as, a permanent methods and all those kinds of things. They are moving towards interim methods. Hello? I am receiving several phone calls which are interrupting. The other important thing, some years back, I traveled to Europe and I realized that the most important form of contraception for women were COCs. So they have gone as far as making COCs, which can be used in quite a number of, even including some medical conditions. And the presenter did first, second, and third, and fourth generation, yeah? And this is entirely dependent on the type of progesterone which is used. So I need to tell you that the most newer and the most recent contraceptives seem to be used in even hypertension and other kinds of conditions. However, it's very important that the students align themselves to contraindications of COCs. This one is a must read. And also, it's very important that we also align ourselves to the medical eligibility criteria of a number of conditions to combined oral contraceptives. It's important also to know which are the most recent types of contraceptives. If I remember, you know, different COCs have got different side effects, and they have got, you know, different kinds of contraindications. But generally, we need to know that. And we also need to know non-contraceptive benefits of COCs. This is also worth knowing, because when you graduate and you're working in a county hospital, the wonder drug for most women's gynecological problems, it is COCs. So this you must know. And then there was a present on special needs, you know, contraceptive for special needs groups. I think this is worth remembering and following, because it's equally very important, for the reason that, you know, different kind of special needs groups essentially require some forms of contraceptions, especially the long-acting reversible one, contraceptive methods which are not user-dependent. I think there is so much to say, but these are just but a few of the comments that I need to make. And there's also need to request that we you know, ensure that we ensure that we align our presentations with the medical eligibility criteria. And I have not forgotten to give the input on HIV and the contraception and the importance of dual contraception, and also the importance of family planning, especially, like, I remember asking a question recently to part of your group on the 4 prongs of PMTCT. So as we say, contraception helps to reduce maternal mortalities. It's equally very important to note that the only way you cannot have, you can have prevention to mother-child prevention from mother to child transmission is through family planning. If you are not pregnant, even if you have HIV, you're not again going to transmit the virus to the baby. I think those are my comments from the group president. I need to know I need to have the list of attendance. I did take screenshots. I need to know those who are sharing from the same group. And the group president, you need to send this presentation with that list to me after everybody has put their important input. Thank you very much.
All right, thank you, Dr. Have a great evening.
Is there a question? Any question?
Question.
Any
There's
question?
seemingly no question, Dr.
Okay, I think then with those instructions, you guys are dismissed, and I wish you well. Enjoy your, what is the name of this holiday coming? Is it? Madaraka. What is the name?
Madaraka Day.
All the best.
Yes.
Enjoy.
Thank you.